All right, so learning and development is one of the most, my favorite function because I'm heading L&D for Care Group of Hospitals, and we've been doing multiple initiatives here for our medical as well as non-medical team, and it is functioned into different aspects like mid management, senior management, and also the junior level team. So we also have learning management systems through People Strong, and there are a lot of things that we can do in terms of learning and development and helping our team to develop across and to ensuring them that there's some career path for them. So I would shoot the first question to you. Yeah, how is technology helping in healthcare education and training?
I think that's a good question to start off with. First of all, I just like to sort of set expectations. Technology is a means to an end. Technology is not an end to itself. But technology definitely in today's world, thanks to COVID and how the world has changed. Whether it's your finance, your telecom. When was the last time you visited a post office? When was the last time you visited a bank? The world is changing, and so you can't really absorb yourselves with technology. It's becoming an increasing part and parcel of our life.
Right.
From a healthcare education perspective, I think it solves three major problems, and in most contexts, it does the same. First is access. In today's world, people are busy. Everybody has busy lives. They want to have the learning when they want, where they want, in the form they want. So it solves the access problem. Second is equity, right? Not everybody gets access to everything every time. There are lots of moats or barriers for access. So LMS or technology really solves that problem. And the third thing is, big initiative is around personalization. Technology with AI and many things that, the tools that are part of these LMSs and other technology initiatives really help address these. And I think, increasingly newer and newer technologies, as they get integrated and become sort of more mainstream, like virtual reality, augmented reality, AI-driven systems, all of this push the boundaries. It can never replace a traditional classroom or hands-on learning, but it does bridge the gap to the extent possible.
I totally agree with you because there are so many times wherein the nurse when we have to train the nurses, the nursing educator is like, hey, madam, please make sure that you give a session which is in person session with some role plays and some realistic question answer round. Otherwise, they're not actually able to understand. But when it comes to say senior management, we can still have some sort of an online learning system. So that really helps. And as Care Hospitals, we've collaborated with ASCII Administrative Staff College of India, and they run a very good program for us for mid-managers by the name of Care Emerging Leaders. So that's going really well for us. So as you told very well that technology is not everything, but yeah, it is something that we're going to focus on in the future. Correct.
Yeah, thank you.
So, all right. So moving on, what as per you is the importance of continuous learning for both medical and non-medical professionals?
So again, I raised the point of how the world has been changing, and especially in the last one generation, I think the world has transformed far beyond what change the world has seen in the last maybe 200 years. For example, the postal service has shut down telegram as a service. I'm not sure how many people are even aware of it. So there is change, but as industries or domains, there are two industries that are most difficult or to see breakthroughs and adoption of new things. First thing is healthcare, and the second thing is education. And now, when you're at the intersection of both, the landscape is extremely tough. Obviously, lives are at stake. People's careers are at stake. But what really happens, between your college days and your formal learning phase of life and then in real life is, where do you get the opportunity to update yourself? How much do you know about what's really happening today? Becomes a big question mark. For example, in any typical college today, how much are they exposed to robotic surgery, laparoscopic surgery, or AI-driven methods for problem solving for clinical or non-clinical scenarios is almost non-existent. Now, unless the entire fraternity, depending on the role, position, experience, are given the opportunity to understand what's happening today, what the customer really expects, to give the best in terms of outcomes. If there is no forum or opportunity to do it, then the loss is, eventually all of us. And so I think it's extremely critical that, the entire ecosystem invests in the time. This is both clinical, non-clinical, and really looks at solving problems and setting ourselves for the next generation.
Okay. Totally agree with you. Thank you for answering that question. How can India become a favored hub for medical education?
So I think, this is a very tricky question because not all of it can be solved by one stakeholder, so to speak. I think first the biggest needle mover for this can be the government. Legislation and policies and governance play a big part in access to education, types of education, quality of education, and so on and so forth. And so, for example, I'll give you one case in point. We also heard a lot about people talking about mental health. But are you aware what is the prescribed faculty-student ratio for psychiatric training in a PG college? Anybody here has perspective on the number? What I'm trying to say is for every student who enrolls, that college needs to have how many faculty to do PG education in the mental health space? It's 1:1. So if you have to provide, even if 500 students need to be trained, is it realistic to expect 500 faculty who are postdocs and then involved in teaching? Some of this, is so archaic that, these rules were framed, at the time of independence. In 75 years, nothing has changed. So fundamentally, we have to relook at a lot of this. The other thing is, landscape change, right? A lot of things that we do here somewhere is almost accepted, but I think some of the fundamentals need to be questioned. Today in cities, if you go to a mall, would you visit the mall again if, say, the toilets are not clean, there's fresh air, it smells good? Would you agree to go to a airline or a hotel where the checkout time for you is 6 to 8 hours? Or if you visit any of these places and you have to really hunt for a parking slot, all of these exist today in our healthcare ecosystem, right? You go to a hospital, any good to great hospital, it's tough to find a parking slot. It's tough to find appointment with a doctor. These are very fundamental issues, right? And somewhere these base questions seem to be sort of swept under the carpet, and then people talk about really high-end technical things, which by no means I'm saying is not important. But I think we have to solve for some of these very fundamental issues before we try to boil the ocean and say we will do 20 other things. Another key point is, in the, not just medical education, but in any education landscape, I'm sure a lot of us here have kids, right? Now, if you're in a CBSE, moving to an alternative board like an ICSE, or moving from class anywhere between 0 to grade 9 is accepted, right? All you need is a transfer certificate. But have you ever tried getting your kid into a different school in class 10? And have you understood the challenges you face? And it gets even tougher the moment you want to go into class 12, right? The big reason is, acceptance of certain criteria, etc., just within the school ecosystem. Now, moving on to sort of higher education, we all talk about acceptance of our degrees in international scenarios. But have anybody tried to move from one college to another or one university to another midway through your education? It's next to impossible in India. Because forget international, our universities don't recognize each other. and they will not allow transfers. So some of these are very, very simple fundamental questions that somehow we don't want to ask, we don't want to address. Now, unless these things are addressed and you move to a more evolved system where you first address internal problems, the opportunity to sort of conquer the world and say, I'll be the MVT destination, I'll be the education destination, will really remain a challenge. And at some level, I think, just as has happened in the banking, in the insurance, in the telecom space, I think India as a country needs to open up the education sector in some form. For us to attract the best universities, the best faculty, the best educational system, so that we are able to reap the benefits without having too many barriers. I think a combination of all of these will really help. So it's a coordinated effort. There's no one magic pill, but I think all of this will collectively lead to a great healthcare future for India.
Thank you for answering that question. My another question is, what are those learning initiatives that you would have done in your company to help people grow in terms of their career path?
I think that's a great question. And, I speak not just on behalf of Aster DM Healthcare, but generally industry at large, on account of, my prior stints in the healthcare space, etc. One of the things is, of course, you need to, if you go to a typical traditional, say an IIM or an ISB or any, good management or a technology or a healthcare institution, a large part of your learning is done by academicians, right? And if you look at the experience of the academicians and the lens with which they look at all of this, starts off by saying, okay, I am a strategy professor or I'm a finance professor. And the extent to integrating real world challenges is by picking up the balance sheet of a company and saying, so this is the optics of it. Now, in reality, I wish it was as simple as that. So at least in our ecosystem, the way we try to do it is first understand what the real business challenges are and how it's different by geography, by role, by clinical, non-clinical, the legislation. So there are multiple dimensions to all of this. So first we sort of understood all of that. Now, by no means am I dismissing the fact that, the academicians have their own contribution to make. So all of what we try to do in terms of curriculum, etc., while we articulate the business challenges and problems, it needs to be anchored, so to speak, in a sort of academic framework, which is what we are used to, for 20 years of most of our lives, right? Or even beyond. And so we try to marry the both. So what we'd like to call it is for the industry, by the industry. That's our method, if you speak. But we don't stop with that. If you look at the programs that we design, all of them have extensive project work that works, because in your work life, nobody bothers about the marks you scored or any of those typical academic barometers, right? What really matters is outcome. So we try to work through the entire learning journey largely by doing and working by groups, because that's how real life is. It doesn't matter whether you're picking it out of Google or the learning material that we give or a friend's answered you. But what are the outcomes, right? For example, an operations problem can be as simple as saying, boss, how do you solve a parking problem in your hospital, right? Or it can be to say, how do you reduce the work, move more outpatients who come to your hospital to being telehealth patients, right? What are challenges there? How would you do it? How would you reduce discharge time, right? So I'm just giving a couple of examples, more from a management lens, but then you will see a lot of this is at the intersection of, what the clinicians do and the enabling functions do. So these are some things that we integrate in the build design, and we follow it up with integrating with our sort of HR processes. So it's not about saying, okay, you did a program, you came out with a certificate, you have some cases. We try to put the money where the mouth is, so to speak, by saying that some of these projects are evaluated and said, how can I invest so that it can drive either a revenue growth for the hospital, or it can be optimization for the hospital, or how can it benefit the overall ecosystem from a hospital ecosystem perspective. We also look at how this will translate to career growth for the incumbent, right? And so we try to map it to say, how does that map to the talent journey of the incumbent? It doesn't necessarily mean that, it needs a vertical growth. What we encourage is, how can doctors become more administrators of hospitals if they are interested? If somebody is in a biomedical function, how can he move to quality function? Or because we are present in about 10, 12 countries, how can these incumbent move and operate in other geographies or take a slightly senior role in another geography? How do these work? And so we do a 360-degree approach. And we have a number of programs, that cut across, clinicians, nurses, doctors, consultants, enabling functions, unique programs for each one depending on their role, experience, etc.
Oh, that's great. Thank you for sharing. And I would now like to ask audience if they have any queries, they can please ask. Can you please pass the mic?
Yeah.
Talking about the technology utilization in the healthcare, the future of technology, healthcare technology, I strongly believe lies in digital twins. Creation of digital twin for the patients will throw a lot of integrated data, which will not only help in treating the patient, even virtually, but also helps in generating the pharmaceutical data. What kind of medicines are applicable to that particular patient. Because it's a kind of simulation technique. Simulate the entire process of the particular patient into a digital twin and study that model only. So it's a question of modeling. What we do in engineering, the same thing is parallel is the digital twin technology in healthcare. So what is your view, observation on that? How much have you progressed in that area?
Perhaps what I'm going to reply may be a little controversial. Okay, so, some of these ideas appear new. Okay, but, since I've been in the education industry, we've seen this for over 2 decades. Okay, the choice has always been there, option is there, availability is there. All you need to do is search and you will find enough of it. Now, there are both free models, there are paid models. Is that going to solve, the problem of, as you would like to articulate, perhaps if I'm getting it right, patient awareness? Maybe, maybe not. How motivated is a person to solve or interested in knowing this is a very, individual decision. He may choose to do it, he may not choose to do it. You may create all of this, but why would someone even bother? What's in it for him, right? Some people like to be more, aware, knowledgeable. Some people say it's a problem, it's episodic. 2 weeks, I take some pills, some medicine, and I'm done. I have to carry on with my life. So they may not be interested. Now, if you want to start a business saying that I'm going to work in the space of patient awareness, I think it's a holy grail. But what will be the economic model? Because you can never mandate it. And do you believe someone will pay money to say, okay, I am taking XYZ drug for diabetes. Is that the right drug? Is it the right dosage? Today, there is enough data, that is publicly available for you to at least do a dipstick to say, is it right or wrong? But who's going to understand, how the pancreatic cells are, interacting with these molecules and all? I don't know. I have my own views. It's not a monetizable idea in my perspective, but juries out there.
For teaching? Because
Again,
we are using AI.
optics,
If you are
right?
using AI, you can as well use digital twin also for teaching students and also nurses.
Again, the question is, what is the outcome you are trying to solve?
Outcome is, the reduction of the staff. You don't need to have so many staff.
No, I don't think it's a direct correlation. So what are you saying? You're saying here are 100 nurses or aspirational nurses, hypothetically, and you want to train them on, say, diabetic drug prescription, right? Now, you may train them. Will the law allow them to do anything? Right? They have to just follow what the doctors prescribe. Now, so in that environment, I understand that, the nurse may be better prepared, may have a better understanding. But today, have you imagined the life of a nurse? Out of 16 hours or 17 hours or 12 hours that she's there, she has to keep standing for 10 hours, right? She's always need to be on the rounds. And she will tell you, the life is very unforgiving. And it's one of the lowest paid jobs in the ecosystem. Do you think she'll be bothered about saying how, pancreas work or anything works beyond a point? She's only bothered about saying, okay, I have to do X prescriptions to Y number of patients. It means I have to do 16 rounds. And my shift is over. I have to go back, cook food for my husband. That's life, right? Now, we all tend to be sort of, look at things from a slightly utopian framework, which is good. It's important for debate, dialogue, discussion. But somewhere you have to stress test it to say, will you do it?
Physical to virtual.
So
it's good to have, but I don't know.
So virtual can also help, but not so much. Maybe not in healthcare, because I've met a lot of people who are into AI tools, and somehow I've realized that for us, when it comes to soft skills, what works best is when you in person go there and you teach those people that this is how you have to behave with the patient. This is how you have to be empathetic. So empathy, compassion, this is not something that we can teach anybody through a virtual class. So that can help, but in a limited frame. Any other questions?
I think we have a couple of more gentlemen.
Yeah.
Ravi Shankar from Create Labs. I've seen that from your discussion that you're having substantial focus on talent development. My question to you was, given the medical errors and the need to reduce them globally, and similarly in India, is clinical skill training and its simulation going to be one of the focus of your academy?
It is. So clinical training is a big part of what we have embarked on doing. Now, the goal is, we loosely say transforming healthcare learning, right? And the optics and lens for it can be multiple. Now, one is reduction in medical errors. The other is learning new technologies, improving healthcare practice excellence, so to speak, on doctor-patient communication. It has multiple facets. Now, a lot of question is that our ambition may be what we have, and we genuinely, sort of try to contribute to the cause. But tell me, in the academy, number one is that, our audience is not just Aster folks. It's, anybody in the healthcare from anywhere in the world are our students. Now, in that context, how do I measure medical errors for people who come and join? So it's a nice ambition to have, but it's not something that I will be very vocal in communicating unless I have unbiased perspective on what has this transpired to in real life, right? But the hope and vision is to say, how can I influence, such positive behavior and outcomes? I think that's a great question.
Yeah, I have a question here. Previously, there was, in rural areas, there is acute shortage of doctors. Most of the doctors who come out of universities, they prefer only urban areas. So previously, that LMP system, licensed medical practitioners, was there. Hospitals like your Aster and others can take initiative in again bringing that LMPs into existence and providing healthcare facilities to rural areas. What is your take on that?
I think it's a very good question, but it requires a much bigger debate. Let me put some realities that we all need to expect, right? Now, whether we operate as a clinic or a hospital, which is episodic intervention, or, the wearables and, other things, IoT, which is non-episodic intervention, whether it is in the healthcare space or you're in the business of tobacco or whatever, as long as you have investor interests in mind, your first KPI is, your top line, EBITDA, growth. Now, it's not for lack of initiative or effort that, hospitals have not gone to tier 2, tier 3 towns, right? Like CARE is a great example. They have significant presence in tier 2, tier 3 towns. Similarly, HCG. There are a lot of people who have experimented with that model, so to speak, including Aster. So we have a separate brand in the Middle East called the Access brand, which, as the name suggests, is for blue-collar workforce where access to quality healthcare is challenged. So it's not for lack of initiative, but we are responsible for shareholder value, right? Now you tell me, in a slightly different context. For example, there have been enough hospitals like Vedanta, HCG, etc. We started high-end sort of delivery of healthcare in tier 2 towns. But all their operations struggled for a while before they could even turn the tide. Now, what is the reason for it? Is not that there are not enough healthcare facilities, but as a customer, these people prefer to go to cities and towns because they believe that better healthcare is provided in big hospitals in cities. And so that internal movement of people to get better healthcare exists even if the healthcare operators open facilities in smaller towns. So it's a challenge and works both ways. While it's not for lack of initiative, we have to somewhere balance the revenue, the social ecosystem to say, how do I motivate them and say, no, you stay here, you can get good treatment here. Why don't you trust this doctor? So it's a much larger solution that we need to think through. I don't think there is any prescriptive answer to say, if I take LNP, suddenly healthcare in the semi-urban and rural areas will suddenly become different. It may contribute, but I don't know. I don't think I am in a position to give you a complete answer.
All right, so we can see the pop-up here which says time up. But thank you so much thank you so much, Srinivas. Thank you so much, everyone, as being a good audience. And we would now like to close.